What I'm up here for is to introduce our first speaker, and he's a gentleman, a doctor that I've gotten to know pretty well over the last year and a half as I have switched my primary monthly care to Grand Rapids, the West Michigan Cancer and Hematology, and the head neuroendocrine specialist there is Dr.Chanadana, and he is going to lead off with a half-hour discussion of the overview of NETs. So appreciative of the care he and his team, and by the way, he's got the best nurse ever. I won't tell you, I know there's some doctors here, so I won't say her name is Linda because you might try to steal her. But Linda is the absolute best person at jabbing butts every month. So too late. Oh, I did. I leaked it. So thank you for being here.
Thank you, Marianne and Bob and Dave, for the kind introduction and invitation to all of us here. And I always say to my patients, stick with your nurse. You know, she's your best friend for life, or he. But I think I happen to have two nurses which we work, but that's great because most of the time what happens is, this is, I should say, neuroendocrine tumor, even it has a tumor or a cancer, whatever word you have, I always tell my patients this is a chronic disease. You know, you heard about chronic diseases, right? You know, hypertension, diabetes, and you know, when the people with hypertension go to their doctors, they don't, you know, talk about life and death. They talk about living and how well we can control. But same thing could happen. You know, we saw in the room how many people have raised their hand, you know, 20 years, you know, and making. You know, this is a great, in the sense that people are living longer and we have technologies to detect and also treat therapeutics, and made a lot of progress in the last 10, 15 years. This is great. And also I should say, I'm going to talk a few things about the details about the disease, but it's a great multidisciplinary you know, effort for all of you. I know that you have one medical doctor and one surgeon, but again, make sure you all actually connected to your program where your care will be delivered by a group of experts who deal with this. That is the key, because we have, I think, Marianne and Bob put together is a great program today. We have a surgeon, and a great surgeon, and also, you know, nuclear medicine physicians. I mean, it takes a little village to take care of patients with neuroendocrine tumors. And I think I happen to have the expertise when leading such a group, and all of us here, great speakers. You will be hearing later today some of the, you know, the talks from them. And so it's always great to talk to some of the professionals, easy, but I think when we're talking to the patients, I mean, I don't know, I mean, you have to get to their level of understanding. It's a tough, but again, I'll try my best. I try not to put like a lot of data, but again, there are sometimes we have to show the data. If you have any questions, please come up after the talk. We can talk about if you have any question about a slide or two. Given that background, I'm just going to move my slides. But I think I just want to introduce myself. I'm Sri Chandan. I'm one of the medical oncologist and hematologist by graduate training. Actually, I started my life in the United States in Detroit. I did my PhD in pharmacology, and I was a lab rat for 4.5, 5 years, and then subsequently went on to do residency and fellowship at Michigan State, and then subsequently worked in community program in Kalamazoo, Michigan, and then moved to Grand Rapids because we're developing a good program, research program. I actually have a clinic for a couple of days, and a couple of days I work in a phase 1 center. It's a hidden gem in Michigan, but a lot of programs there. But we're trying to develop a program which is useful for people. They don't have to travel to big centers, but close to West Michigan. That's our goal. There's a lot of momentum in neuroendocrine tumor. We have some trials which are geared towards that. I think we have, these trials are not easy to bring in, but we have some opportunities. But of course, all over Detroit and U of M, you're in a great place, great state. You know, any help you need. With that, so I'm going to kick off the program with these are the objectives, what we are going to do today, learn. I'm just giving a basic understanding of what this disease and to build upon other experts to, further. This is kind of a baseline. I put together some slides to understand, but I apologize if I use, and a lot of people know a lot of things, but I just want to make sure everybody in the same page so that we can build upon other speakers. So we're going to talk a little bit about epidemiology, how big is the problem, and then pathology, more important, clinical presentation. Sometimes this disease could be diagnosis, could be people present with bizarre symptoms, but hard to, I always call it, if you want to find a zebra, this is it. I always tell my residents, actually, if you have, everybody in the room gave all the differential diagnosis, nothing is correct, please yell from the back, it's carcinoid or neuroendocrine. It's always probably correct if people doesn't. So people present with lots of we're going to learn about a little bit. And then diagnostics and laboratory and imaging and some of the biomarkers and treatment options. I'm not going to touch upon every treatment. I'm just going to give a baseline, and then other speakers can build upon that. Yeah, so it's a complexity of NETs in general. As you can see in here, neuroendocrine tumors, I mean, obviously, it's a name, but it can arise in a lot of organs, as you can see here. And your, it can arise mostly in GI, foregut, midgut, and hindgut. I mean, there is also in the lung, and you also can have in other areas in the ovaries. I mean, in rare cases we saw primary could be from ovary or thyroid and other places, but luckily most of the cases are GI tract and pancreas. So that's what our focus today. The GEP NETs, the gastroenteropancreatic neuroendocrine tumors. That's what the title of our talk today. But there is a lot of other smaller percent of the patients with other primaries, but I think we follow the same rules what we for GEP NETs, but a little modifications here and there. Next slide, please. So a little background here. So there are a group of rare tumors, relatively rare, I should say. It's increasing the incidence, but so these are relatively rare compared to other cancers like lung, breast, arise in the neuroendocrine cells. I mean, there are some cells which are very important for normal physiology, and these cells get mutated or somehow, and then they get into tumors. So in the GI tract or pancreas, capable to produce a lot of other, most of these symptoms are from because they produce a lot of other hormones and also some of the serotonin, which produces a lot of underlying symptoms. There is a various histologists. We'll talk in a bit. I mean, it's not like a one thing we can just, there is a low grade, high grade. We'll talk a little bit. It's a great mimicker for a variety of diseases. For example, that's what I said. It's like a zebra. Basically, sometimes you think it is IBS. A lot of people come to see me and then it's IBS, and actually it turned out to be they're treated for IBS or something for 2 years, and voila, patient 2-3 years later present to the hospital with some bowel blockage, and there's a tumor there. But their primary care give them some of the symptomatic treatment for those. Anyway, it's a great mimicker for a lot of other conditions. Tend to express somatostatin receptors, which is very useful for diagnosis, and also we have imaging, and we also have some therapeutics based on drugs which is targeting the somatostatin receptor and cause some treatment, basically. So just to give you an idea, foregut is basically the part of the, the intestinal system. As you can see here, it's a simple diagram where midgut and hindgut, and also in the pancreas, it's a separate organ. They behave a little differently than GI nets, gut nets. Next slide, please. So incidence is increasing. This is a data put together by Dr. Arvind Dasari from MD Anderson Cancer Center. They looked at the SEER data, see what is happening in the incidence of the neuroendocrine tumors. As you can see, the orange bar, it's keep going. They have data from 1973 to 2012. As you can see, this incidence is increasing. Thank you. Thank you. Compared to the other tumors, I mean, it is actually increasing. So we need to be a little bit. This could be from various reasons because we have a lot of knowledge. I mean, especially in the PCPs and other doctors are finding it early. That could be one thing. And then we also have sophisticated technology to find, and also possibly some biomarkers. It is. You can see here there's various organ-based nets. It is increasing. As you can see, all of them, most of them are in upward trend from 1970 through. So there is a small paper came out recently. Everybody thinks that this NET is a disease of a little older patients, but again, as you can see, 5% of the patients are less than 35 years old. But it's also relatively not common, but it's not unheard of. As you can see, younger patients always present with some early stage and also well-differentiated GEP NETs, and possibly with a surgical intervention, they could be potentially cured. I mean, I think this is not anything unheard. I just want to bring, because young adults, I mean, all these things, we are all, that's an important area. We're not, it's not only for patients 40 or 50 above, but it's also, we're seeing it more and more in younger patients as well. So it's a slide, I think I took from a publication 2009, but now people are living a very long, but they only have 9 years on this, but I think this changed quite a bit. But why did I put this one in here? Because if you see on the top of the graph, estimated time for the diagnosis is 5 to 7 years. You see that? That's very important to know, but a lot of people go to their doctors. Unfortunately, the symptoms are not anything like specifically tell us this is what the neuroendocrine tumor, but I think they run around the specialist, and I'm sure most of you, I mean, in the room have the similar experience, get symptomatic treatment, turned out to be diagnosed, 4 or 5 years into the onset of symptoms. So I think it's important to have awareness campaign to even physicians, primary care physicians, to suspect something. I have a patient come in with the diarrhea for about 3 years, and their doctors thought that it's IBS, but I think one of the nurse practitioner, doctor was not there, but a GI doctor was not there, but she figured out, I should get a CT scan on this man. So then what happened was CT showed a bunch of liver lesions in biopsy-proven neuroendocrine tumor, but he's following with them for about 2.5, 3 years. But I think level of suspicion is important. So this is a slide looking at what is the symptoms that you come up, a variety of vague symptoms. As you can see, most commonly on your right-hand side, there is some percentages here, but diarrhea is relatively more common, but also followed by some of the flushing. We see some vague abdominal pain, non-specific, some skin lesions, and respiratory symptoms. People present with asthma-like symptoms, as you can see here on your left-hand side, a list of symptoms I put together, but this is only a select few. People have anxiety attacks and allergies, I mean, including food allergies. IBS is a big thing. People will have and thyroid problems. I mean, sometimes, I have patients who they were sent to neurologists and psychologists or psychiatrists thinking that they have some psychosomatic psychological problem. It turned out to be that it's a neuroendocrine tumor, because if you're going to see your PCP and you're telling the same thing for 3 years, 4 years, they think it's crazy. And but I think we got to be careful, and when we diagnose people and rule out some of the conditions, whatever we can physically, a scan or something. So anyway, arthritis and skin problems, chronic and unusual abdominal. These are only just a small list of things I put together, but this is what I hear in my clinic. A lot of times people present chronically, but there's a lot more unusual symptoms people present with. So why is it so it's important? These are because these tumors produce various hormones or molecules which will cause these symptoms. Sometimes, for example, you have serotonin is a big deal. I mean, it actually produces some of the flushing and some of the diarrhea. that we incur with. But also, if you look at the pancreatic nets produces a lot of hormones. For example, as you can see here in the gastrin, it actually involved in this gastritis and then, heartburn kind of symptoms. Insulin, some people come up with, a lot of people doesn't figure it out. I mean, they keep falling at home. And then nobody thinks that their blood sugars are dropping. They think they're stroke or other things. Finally, somebody will think about, what about the blood sugar? When they go to the ER, blood sugars in 30s and 40s, and because it's the tumor secrete insulin. And then same as glucagon, their sugars goes up, and somatostatin and histamine, and these are, I've just put together just to see that how the complexity of some of these things, what hormones these produce. But this is a small list, but there's a lot more non-specific biomarkers you see on a yellow table there. There's a lot of other molecules, but this is a lot of research ongoing in our clinics and around the world. What is the best biomarkers? We all use chromogranin A, but it's not the most sensitive test, but we use it because nothing else is good, better available, but we use it. But all of us agree, maybe that's not the best test, because if you eat a couple chocolates or some avocados, the numbers goes up quite a bit. So interpretation is important too. And so anyway, we need a lot of work in this biomarkers. So this is actually, I just put completion's sake, I apologize for the complexity. This is what we go through as physicians. There's this NET classification changes every 2 to 3 years. Pathologists sit around the table and change it quite a bit. But this is the latest 2019. As you can see here, they use 2 factors apart from differentiation. They look under the microscope and tell that it's a well differentiated. That means it is making patterns, well-designed patterns, or poorly differentiated. What does that mean? Look bizarre. Each cell next to each other doesn't look alike. So we can do that. Well differentiated, poorly differentiated. Then use a couple of other markers of mitotic rate, how they're dividing mitotic index, that's what we call. And then Ki-67, it's a stain. I look at how bad their more brown means their Ki-67 is, when you put a stain, the cells turn into brown. That means higher the number, worse the proliferation of this cells. So they're very active tumors. So less is better. So we usually look at some of the numbers less than 3 to 20, and then more than 20. As you can see, we use these factors to differentiate it, well-differentiated tumors, but well-differentiated have grades, grade 1 and 2. I'm sure you discuss with your doctors, and grade 3. Anything grade 3 is usually needs sometimes chemotherapy and so on and so forth. Grade 1 and 2, we have opportunities, wait and watch, or use some of the treatments what we are using, somatostatin analogs and some of the somatostatin receptor Lutathera kind of drugs. But point is, I think there's a high level of complexity here to figure it out. I mean, these numbers, putting everything together. That's why we are on the tumor board and pesting the pathologists is, hey, can you tell me some Ki-67? Some communities, they said they won't even do some of these things. Very important to know your disease and differentiation, because that makes all the difference. Grade matters, because your treatment depends upon what grade. Grade 1 is better than grade 3, and we can treat accordingly. So the diagnosis, this is the steps that we go through. Of course, you all went through the same. History is the king. That's all right. But unfortunately, now with this DNA age, a lot of people not spending time with, we're only interested in imaging and whatnot. But this is the important, I think this is a lost art current. But again, history, spending time with the patient is the key. So the patients tell you that they give you the diagnosis, but you're not listening. That's what I tell my residents, and when I'm teaching, please sit with them, and they tell you all the symptoms, what you need to make the diagnosis, but the only problem is we're not listening to them, okay? So getting that history is the key to even differentiate some of this wide variety of the nets. And so that's what I think first thing is that the physical exam, there is some findings, you can figure it out, like a flushing. I have a patient who when I first saw her, face is like very red, like tomato, and I just, somebody asked me to see that patient with some intern made a great observation and then sent patient to me. And I said, I looked at her face and is like very red, flushing. I said, I ordered some a chromogranin and a scan, and voila, that's, we found it. So anyway, I think that's a physical exam is very, laboratory data, we have some labs. I mean, we all do CBC, CMP, look for liver function, kidney function, but more specifically, there are some specific tumor markers, chromogranin A we use, but it doesn't have great sensitivity, but again, we can build upon it. And then in carcinoid syndrome, you heard about some of these symptoms. We use 5-hydroindolestic acid. It's one of those. You can do serum, or you can do urine. Urine may be better. And then you also, depending upon symptoms and what your level of suspicion, PNETs, we always look for these insulin levels, gastrin, VIP, glucagon, you name it. There's a bunch of hormones we check. If those are elevated, that means those are functional tumors, which produces all these things. But that has implication for treatment and so on and so forth. Imaging, we're getting better and better. As Marianne mentioned, Octio-scan was there before, but now we have novel PET CT scans and PET MRIs. I think people are bringing more sophisticated technology, but suffice to say, there's one thing, gallium dotatate PET scan, actually upstage a lot of patients, find these tumors, and looking at some of the so I just put together, some of the physics behind, because I have a PhD in PET tracer development. So this enticed me. I guess this is only for myself. This how gallium works. Gallium emits the positron, and then when it combined with nearby electrons, they actually release 2 photons, and then the ring of detectors will detect. As you can see that pictures on your left-hand side, you can see that bright spots in the liver. You can diagnose with some of the tumors, but the one problem is the resolution may not show any small tumors less than 1 centimeter. So smallest the tumor probably may not be, but CTs, MRIs we use, we still use MRIs to, I think Dr. Howe here uses all the time to figure it out, apart from this PET CT scans to see when he go in and make his plan for surgery, he rely on some of these CTs and MRIs as well. So this is a scan. I think I want to spend a minute. It's very important for localization of the primary tumor. Most of the time when people come in, we don't know where the tumor is there, but sometimes we can find out that it's a small bowel or something. And extent of the disease, it is actually specific. If it is positive, it's specific for neuroendocrine tumor, and it's there is some data if you have a PET positive, maybe a favorable program. So what are the treatment options? Basically, so these are some general surgery, local regional therapies. I'll talk to you in a minute what those are, and then PRRT. I mean, this is the talk of the town, and also systemic therapies. Okay, let's move. Okay, and so surgery. I'm not going to go too much. We have Dr. Howe, world-renowned surgeon here. I'm just going to go a little bit about the resection of the primary tumor. We always do that, and also we do cytoreductive surgery. I think Dr. Howe and others published papers, and if you take maximum debulking of these tumors, wherever they are, even liver, I mean, they do liver resections, more tumor you take out that actually turn into survival benefit. Actually, there's a lot of data. That's why we sent patients, even though stage 4 metastatic, we always send patients to see our hepatobiliary surgeons, and then they take care of the stuff. I mean, so that's, I think Dr. Howe may talk a little bit more about that. And then we have local regional therapies. You can have, if you're not able to do surgeries, I mean, sometimes we do radiofrequency ablations, and then some local radiation therapy. For example, if somebody have brain mets is very rare with low-grade neuroendocrine, but high-grade neuroendocrines, we have seen it. that the local radiation sometimes to alleviate pain, brachytherapy for liver metastasis, but it's falling out of favor. But we do, it's in a bad location for surgery. We do that sometimes. And then more importantly, embolization. Interventional radiology has a very handy for most of the centers that they can do chemoembolization or radioembolization. We have lots of options for liver-directed therapy. We do this all the time in conjunction with systemic therapy, which is basically we're going to talk in a minute. Now we have also tumor-targeted radioactive therapy. This is a targeted. We're tagging alpha radiation, small radiation particles, to the somatostatin receptor. It's like a switch and bait. I mean, you send this radiation tagging with somatostatin receptor, and they go and bind to this target on the tumors and deliver the radiation therapy. That is, now we know it's called PRRT, based on some of the work done. This Lutathera, lutetium dotatate, is now approved in the clinic, and a lot of us using it quite frequently now. And then the only problem is, when it is originally, there are select centers, availability of the center, you have to drive 2 or 3 hours, wherever you're locating. We were using U of M, but now we're getting this drug available in Grand Rapids. We're just a month or two away to treat our patients, so we're happy about that. Our patients doesn't have to go to either east side of the states, so that's good. Systemic therapy, as you can see here, one of the picture on your left-hand side, there's a lot of receptors on this is one of the neuroendocrine cell. We actually, maybe look under a microscope or mega microscope, you'll see inside the cell, it's a cartoon depicting some of the molecular players, which regulates this cancer. So we're developing some targets who are involved in the cell growth and cell proliferation. You see on the cell surface there is a lot of somatostatin receptors, so we're tagging those. Your lanreotide or octreotide, that's what it does, go and bind to those receptors and make them actually not to proliferate the cells, so keep it stable, or and maybe some cell death. And then there's inside the cell, there's lots of players we're targeting, like mTOR or other vascular endothelial growth factors. But again, there's drugs approved, as you can see here, mTOR inhibitor, otherwise called Afinitor or everolimus. And then we use VEGF inhibitors, and sunitinib, Sutent is the drug, tyrosine kinase inhibitor. It's already, and then we are developing a lot of other drugs. And chemotherapy, least but not last one we choose, but if nothing is working, we even give chemotherapy. For example, capecitabine or Xeloda in combination with temozolomide, based on the work from Bob Fine at New York, there was a phase 2 trial which was actually showed, and then now we have the data from ECOG trial as well. So I'm just going to skip the trial, some slides because of the interest of time. These are the 2 trials led to the approval of the somatostatin drugs, the sandostatin long-acting, and also the lanreotide. I just want to show you this is not based on what people thought. It's a randomized phase 3 trials. And then you can see here other tyrosine kinase inhibitors, sunitinib on your left-hand side, and right-hand side, everolimus, Afinitor. As you see the curves, curves means, the drug is working compared to placebo. So these were approved. And then this is work done, multinational collaboration in here, another one trial looking at Lutathera or lutetium dotatate compared to choice of treatment. As you can see here, curves separated from the get-go. It is a progression-free survival. That means what is the time take for people to, how many % of the patients to progress. As you can see, the Lutathera worked well for patients, and that led to approval. And then this is one of the trial, this is the ECOG trial led by Pam Kunz at Yale University, so led to approval of the capecitabine and temozolomide. Recently, there was a follow-up on this. There's no survival benefit, but PFS is good, so we still use this drug in patients. So this is a summary slide for some of these trials. I just want to, for completion's sake, but again, I don't want you to get scared with this slide, but it's busy. You have I just want to show you how complex your doctors are thinking about, using what targets to use, and I just want to simplify. It's a simplified cartoon. Life is not simple anymore, but you have to think about what drugs to use based on some of these molecular mechanisms, and scientists are developing based on biology of this particular cancer, but I just wanted to put it there to see how complex and what we think when we think about your treatment options. And important thing, my key is patient and tumor characteristics. How do you choose a treatment decision based on how you are doing, your symptoms and your tumor burden and your other characteristics, like you have a positive somatostatin receptor imaging or not. So how aggressive this tumor is, I think we always do. Yeah, let's do a close follow-up imaging. See, we want to see the pace of this disease. Most of these diseases are very slow growing, but again, if it is actually getting growth faster, we use sort of a chemotherapy. But if it is not, then we use the lanreotide or octreotide or somatostatin LA, and so on and so forth. I just wanted to show you how your doctor is thinking about making decisions, what factors. But this is a small cartoon just published recently in one of the journals. This is authored by one of our, Dr. Kunz from Yale University. So put together a small, what we do in the United States, how we treat these patients. As you can see here, if you have a local regional disease, that means a patient present with small intestine, small bowel NET, we don't do anything else other than sending them surgeons. They do surgery. Even if a regional get to lymph nodes, we don't usually give anything. It's probably stage 1 to 3. We treat them with observation, close follow-up. But I think obviously we are trying to figure it out how a lot of people actually have imaging follow-up. But I think we are now working on circulating tumor cells. See whether we can detect the cancer is on the move to the liver. How do you detect early? We do imaging maybe every 6 months, every year, but how do you find out the smoke before the fire? So there is a lot of research ongoing in that area. How do you find, and then if you have a low-grade NETs, we always use either observation, depending upon your symptoms, or we use, put them on lanreotide or octreotide. That is suffice for most of the patients. But if the tumor is not responding, and obviously if you have PNET, we usually give somatostatin receptor imaging. If you have imaging positive, then we have actually a drug, Lutathera, we use when they fail on, or maybe progressing on, the drugs, octreotide or lanreotide. And then if necessary, we use this other drugs, the everolimus or Sutent, and then certainly when patients are progressing from that. But grade 1 and 2, we usually get, you see your doctors, like even though you see the tumors on the skin, they take a laid-back approach, but it's not because they just don't want to do it, because there is a time, it comes when we have to use all of these things. So sometimes it's going to be a difficult discussion with our patients. If their tumor is growing slowly, we'll say, let's see what the next 6 months brings or 4 months brings to us. But if I am the patient's shoes, you say, what is going on? Doctor didn't pay attention to my scan, but no, it is not. Actually, the rate of the growth is important, and how much we have to, in your lifetime, we have to use all these treatments. So your doctor is thinking, keeping all these things in back pocket rather than using in because there was also side effects to these drugs, right? So anyway, it's a nice, and then if we have a grade 3 or poorly differentiated carcinoma, we always use chemotherapy, especially with large cell, small cell, poorly differentiated. We have to treat them just like with the chemotherapy. And now a lot of trials are ongoing with other therapies such as immunotherapy. And I'll have a slide. What are the future directions? As you can see here, most important thing is I just want to tell the awareness is so important because this disease is underdiagnosed. So I usually, when I have an opportunity, residents and primary care physicians, I myself actually brag these things to them. It's like, please think this is like the back of your mind always for any condition actually. And then, patient education is key. I'm glad that you're all here and learning, but I think if you educate and empower yourself, I mean, you're your best advocate, and of course, Dave is there in Michigan for everybody, but I think learning this disease is very important, crucial. And then novel biomarkers with the great specificity and sensitivity. We don't have chromogranins there, but we could do better. And as I said, circulating DNA or RNA, the technologies are coming, but we don't have enough confidence to see that works or not. It's still in research. Sequencing NGS, that means we're opening up the tumor cells and studying the 400 or 500 genes, see which one is driving or not. So we have a lot of information, but again, we don't do it in low grade, but high grade certainly we do. Because we find some targets, we can target it. But because nowadays we're not treating any cancer, just like because it's a breast cancer, I mean, of course, or pancreas cancer. If I find a target, we have a drug approved, we are always moving in that direction when they fail on traditional treatments. And of course, biotheranostics, I mean, the diagnosis and treatment is the same molecule can be used, diagnosing and also treatment. There is we have excited to see in Grand Rapids where there is a research organization coming up with the help of some philanthropists, rich philanthropists in Michigan. So stay tuned. There is a lot of momentum in Grand Rapids. Clinical trials, I mean, obviously, we have a lot of late phase and early phase. We are bringing a trial looking at, Lutathera versus chemo, Xeloda and Timodar. That's one of the ECOG trial we're working on getting in our center. And early phase clinical trials, I mean, if somebody ran out of options, obviously we still have, let's say somebody is 25 or 30 years and they need something, but most of the people are healthy. So we were able to get Dr. Chauhan and myself, we're very much involved in this, bringing some novel therapies, and a lot of others are trying, but I am happy to say I work at a phase 1 center in Grand Rapids. We have lots of molecular targeted therapies, and if anybody needs it, but anyway, there's a great opportunity there. I thank you for listening and learning and teaching me a thing or two. And also, I hope, I know summer is here, right, officially? So hopefully we can have some good time this summer. Okay, thank you. I think there's a question and answer session, so we'll keep our questions for later.